first time with this 2021 round of the GBD. The GBD is releasing subnational estimates for Italy, which cover 19 regional and 2 autonomous provinces. So we published our first paper on Italy in 2019, which was based on GBD 2017 estimates and could not count actually on subnational estimates. Regions in Italy present differences in terms of age structure, SDI, and quality and access to health services. So for this reason, subnational estimates are invaluable for us to be able to assess differences and inequalities among regions and their epidemiological profiles. The study highlights considerable regional disparities as expected in Italy's health outcomes, driven mainly by different population structures, heterogeneous quality and access to health services, and economic inequalities, also, which is something that we know. Regions in the north are wealthier than regions in the south, and different also distribution of risk factors. So we have hierarchical consumptions in the north, for example, but higher BMI in the south. Plus, we are seeing increasing fatal burden of Alzheimer's disease, increasing incidence of type 2 diabetes, increasing mental health disorders, especially anxiety and significant higher life expectancy in females more than males. Life expectancy is quite high in Italy. It's 82.65 years, and it increased 3 years in the last 20 years. But several considerations can be made looking at the figure. Even if life expectancy in males increased more than in females, 2.5 for females and 4 years for males. Anyhow, in 2021, it was still lower for males than for females in the year 2000. So this still it's a significant gap. In Italy, the fertility rate has been below replacement level of 2.1 since 1976. So up until recent times, no significant action had been put in place to mitigate this trend, neither on the side of fertility rate nor on the side of healthy aging policies. Now, today, the actual fertility rate is 1.24, one of the lowest in the world. So the aging of the population reflects on our epidemiological profile. So especially in some regions in the north, the burden due to comorbidities and non-communicable diseases is high, affected by the cumulative effect of metabolic risk factors. There are two main differences between regions of the north and center and regions of the south and islands. The first is related to older population structures, as I said, of the regions of the north, which translates into higher YLDs due to non-communicable diseases and higher rates of comorbidities. The second can be seen if we actually use age standardized rates. We see a higher burden in the southern islands in the younger population due to higher exposure to behavioral and metabolic risk factors and lower access and quality of health services. Among 3 years differences, we can see between the regions with the highest and the lowest life expectancy. This is also an important result. And since 2010, the increasing curve has flattened for both males and females. And this is also due to changes in the economy of the country and the access and quality of health services. And then we can see the impact of COVID on life expectancy, which was delayed in the regions of the south and islands with respect to the regions in the north and center. These maps reflect what we previously mentioned about the different distribution of the fatal burden of disease. If we look at the crude burden, that is just rates of years of life lost. In the first figure, we see how especially Liguria, Friuli Venezia Giulia, and Molise suffer from having older populations. So region number 8, 7, and 15, which are more reddish. If we look at the age standardized YLL rates, that means adjusting for differences in population structure. We see how, as mentioned before, regions in the south, and especially Campania, which is number 16, Sicily, which is number 20, and Calabria, which is number 19, have a higher burden in fatal age-adjusted rates.